Dr. Chandana Prabhakar would be presenting on LUMI indent, an economical and handy scleral indenter cum retinal transilluminator.
So, good afternoon everyone. I am here to present my paper LUMI Indent, an economical and handy scleral indenter cum retinal transilluminator. These are my co-authors. So, we know in a vitreoretinal surgery, we need to handle multiple instruments by the vitreoretinal surgeon and the assistant. Usually, the endoilluminator and the occlutum will be handled by the vitreoretinal surgeon, and the assistant will be performing the procedure of scleral depression, that is scleral indentation. So, there are chances that there will be incidents of miscommunication which lead to slippage, and there can be chances of accidental retinotomies happening in the vitreoretinal surgeries. So we have identified a problem that we need multiple instruments and multiple hands to handle that thing. So there are chances of complication leading to accidental retinotomies due to miscommunication. So we need a simple frugal tool to advocate this problem. So we have found out a solution by combining the scleral depressor and endoilluminator into a single instrument. So the surgeon can perform scleral indentation and transillumination by a single instrument. So we have made an instrument called the LUMI indent, which will perform scleral indentation and transillumination in a combined way. So it's made by three things: endoilluminator, a hypodermic needle cap, and a micropore. The endoilluminator is placed inside the hypodermic needle cap and is secured in place with the help of a micropore. So this is how we have done it in the OT. The endoilluminator is being placed into the sterile hypodermic needle cap, and it is secured in place with the help of a micropore, and this can be used as a combined scleral indenter and retinal scleral transilluminator. So the surgeon can single-handedly manage the scleral indentation and transillumination. So this is how the retina is visualized during the vitreoretinal surgery by using LUMI indent. You can see the scleral indentation and the transillumination. So while using LUMI indent in the OT, we have observed that myopic retinas are easily visible using LUMI indent compared to other cases. So pondering on what could be the reason for that, we have thought that the scleral thickness could be a reason for that. So we have proposed a study that aimed at establishing the relationship between scleral thickness and scleral transillumination. For that thing, we have proposed a prospective study, a questionnaire-based study. It was done in a retina department of the tertiary eye care hospital. Sample size were taken as 200, and the study period was between November 2023 and August 2024. And we have for all the patients who underwent the vitreoretinal surgery, we will take the scleral thickness prior to the surgery by using OCT. The scleral thickness was measured in all the four quadrants: superior, inferior, nasal, and temporal. And the normal scleral thickness was kept standard as 0.5 plus or minus 0.11, 6 mm from the limbal border. And the vitreoretinal surgeon will use LUMI indent while performing the vitreoretinal surgery, and post-surgery this questionnaire will be answered by the VR surgeon. The scleral thickness will be already entered in the data, and the vitreoretinal surgeon has to enter the score according to the visibility he had in the OT. So the scoring system was that score 1 was given to peripheral retina clearly visible, 2 means slightly hazy, 3 means barely visible, and 4 means fundus details not visible. And by compiling the data, we have come across this conclusion that the number of cases with normal scleral thickness was 62.7%, with increased scleral thickness 11.4, less than normal scleral thickness 26%. Among the normal scleral thickness, score 1, that is the retina clearly visible, was seen in 12%, score 2 25%, score 3 33%, and fundus details was hard to see in 30%. In case of increased scleral thickness, it was 6%, 18, 35, and 41%. In less than normal scleral thickness, 23, 38, 21, and 18%. And we have also made a comparison in scleral quadrant ways. It was seen that the superior, the score 1 was in 24%, score 2 32, score 3 41, score 4 3%, temporal 15, 34, 39, and 12, and in inferior quadrant 12, 27, 34, and 27, nasal 19, 36, 38, and 7. The graph will provide a more visual analysis. That is, the scleral thickness is in the normal range. Then the retina is seen in 2 and 3 score. That is, it is either slightly hazy or barely visible. When the scleral thickness increases, the increased average scleral thickness will lead to the fundus detail not being seen clearly. And if it is less than normal average scleral thickness, the fundus details are more easily visible. The score will shift more in the 1 and 2 range. So comparing the scleral quadrants also, it was seen that in the superior scleral quadrant, the transillumination efficacy was more better. Score 1 and 2 was more seen in that quadrant, and the most difficult was with the inferior scleral quadrant. The temporal and the nasal has comparable data, and among that also the nasal has more effective transillumination compared to the temporal scleral quadrant. So we have concluded that the scleral thickness is inversely proportional to transillumination. So once scleral thickness increases, the transillumination efficacy decreases. And in the study, it was found out that the superior scleral thickness was less than nasal, less than temporal, less than inferior scleral thickness. So the limitations also studied that the factors probably influencing transillumination that was kept untouched in the study was retinal pigment epithelial density, intraocular pressure, phakic status, and the axial length. So in OPD, we can tie an alternative for an LUMI indent. That is, we can use an insulin syringe, an LED bulb, which is connected through a wire to the battery. This is how we have made it. An LED bulb is placed inside an insulin syringe and is connected to the battery through a wire. And we have used it in this way in the OPD. So we can perform scleral indentation, and we can also get transillumination while using indirect ophthalmoscopic examination. So in a nutshell, this is the first clinical study based on LUMI indent. It was the first study comparing scleral thickness with transillumination intensity while examining retina. And in the order of best quadrant for scleral transillumination in Kerala population was found to be superior more than nasal, more than temporal, more than inferior. And pre-op assessment with OCT can be done to predict if scleral transillumination can be performed efficiently during the VR surgery. These are my references. Thank you.
First thing is that the size of the intraoperative use, that syringe cap. So sometimes one of the reasons probably you said the inferior quadrants are more difficult could be because it was not able to go as deep like you would see in the superior and temporal quadrants. Inferior quadrant usually is not very easy to go in. That could be a reason. Plus you didn't talk about how deeper or how posterior you were able to reach with this such a big device. It's not a small device. The needle size, cap size is quite big actually. That can be limiting factor. Apart from the choroidal and RP health.
Okay.
And also you said the thickness was measured 6 millimeters or 6 centimeters from the limbus.
6 millimeters.
So that may not be depictive of the scleral thickness much more posterior, because you are depressing way posterior and the measurement of the scleral thickness is so anterior, and you are trying to correlate these two, which may not be ideal thing to do.
Okay.
So in case you really want to do, you could have done an MRI to assess that will be, not cost effective, but that will be the true way of identifying the scleral thickness in the area you want to indent. Okay. So you are measuring the thickness somewhere else and trying to postpone or project that finding to some other area. And the scleral thickness may not be the same in anterior as well as in the posterior.
Okay.
So there are so many limitations of study, and I'm not very sure about that the conclusions are valid actually. Thank you.